America had expanded and was on an upward swing through the 60s and 70s, but things were beginning to change as there were large, very rapid growth in urban places, and that the mix of employment in agriculture was changing. We were going from a nation that had 20% of people employed in agriculture in the 60s down to under 10% and then close to 5% by the end of the 80s. So this was a real shift in the economic structure of rural places.
We had hundreds of thousands of farm foreclosures during that period of time. So we had thousands and thousands of independent farmers that were being put out of work.
There was also a shift in manufacturing. There were rural places that had manufacturing facilities, like in North Carolina, where we had textiles, and they were having to compete globally and were closing and began to close at a very rapid rate from the late 80s into the 90s. And this was really changing the nature of really the economy of rural places. This had an impact on the ability of a hospital to stay open because people were having to move to find jobs.
The hospital in most of these small rural communities is the largest employer. And so it's not just that the economy was getting more difficult for farming and also for industry, but the hospital itself, when it closed, you lost a lot of jobs in that local community.
The 1980s and 90s were generally good economic times for the nation as a whole, but not so much for rural communities, as we witnessed rural economic decline that amplified the problems with Medicare, as well as underfunding by Medicaid in many states.
In about a 4-year period of time, we had about 400 rural hospitals that shut down and many others that were at risk.
For the communities who lost their local hospital, it was very personal. It meant a loss of jobs, a blow to pride in the local community, less ability to attract new job-creating businesses, and above all, a loss to a closer source of care during a medical emergency.
It was very difficult for rural communities when their local hospitals closed. One, those local hospitals provided access to health services. But above and beyond that, it really got to the core of, are we a vibrant community?
You start putting that together and then combining with the fact that we were changing the reimbursement system in healthcare to what was called prospective payment. That was driving the foreclosure of many, many rural hospitals.
Basically, on the 1st of October 1983, Medicare implemented a payment model for most hospitals that was tested only in several large teaching hospitals in New England. They didn't do a trial run in small rural settings, or to the best of my knowledge, did they think very deeply about the impact on smaller rural hospitals. It started by carving rural out from all other hospitals and giving them their own lower national base rate.
The reimbursement rate for services provided in rural areas, both for the hospital side as well as for the physician side, were markedly lower than they were for the urban counterparts providing exactly the same service.
So you start combining all of these factors between people, small communities, lack of services and resources, just driving people to their knees, that there was an urgency in the country for people to pay attention to what was happening in rural America. And so that really was almost like a battle cry amongst healthcare professionals to do something different about how to serve rural America.